Hi, I'm Dr. Bec Bennett, and you're tuning into the AIMER video series, a practical, research-informed program designed to help hearing care professionals provide holistic care by supporting the social, emotional well-being of clients with hearing difficulties. If this is your first time joining us, I highly recommend going back and starting with video number 1 so that you can follow the full story from the beginning. But if you've already seen the earlier videos, welcome back. Today, we're diving into video number 3, Why AIMER Works, the science behind the framework. Let's get started. So how did we create AIMER? Well, let me take you back to the start. I've always been passionate about supporting the social and emotional well-being of clients. As a practicing audiologist, I was struck by how two people with the same audiogram could have such different outcomes. One client would thrive with hearing aids, while another, with the same level of hearing loss, would still feel isolated, left out, or emotionally overwhelmed, even though they could hear better with their new hearing aids. And that disparity got me curious. I started listening more deeply to my clients' stories and realized that a critical part of their journey came down to how they coped. Now, coping is often thought of as simply managing, but it's much more nuanced than that. Someone might think they're coping because they're getting through the day, but they might be withdrawing socially or avoiding challenging situations, which is more of a survival strategy than a growth one. We can think about coping in 3 dimensions: behavioral, cognitive, and emotional. Let me explain what I mean. Behavioral strategies include actions like asking someone to repeat themselves, sitting closer to the speaker, or choosing a quieter space, all helpful adaptations. But negative strategies might look like nodding and pretending to follow a conversation, or avoiding group situations altogether. And then there are the cognitive strategies, our thought patterns. Unhelpful thoughts might include, I'll never be able to hear properly, so what's the point? Or, no one's going to change the way they speak for me. Or, it's my problem, I don't want to burden others. But adaptive thinking might sound a bit more like, I'm not the only one struggling in this room. Maybe others would also benefit if the speaker used a microphone. Or, I seem to have chosen a seat that's making it difficult to hear. I'll move closer. Or, if I ask my partner to repeat themselves, I'm actually showing that I value what they're saying. And finally, emotions. So coping positively can feel like gratitude when someone accommodates you without fuss, or relief when others also admit they're struggling to hear. It might feel like pride in doing something difficult, like wearing hearing aids for the full day, even when they still feel unfamiliar. On the other hand, negative coping emotions might feel like overwhelm, or frustration, or hopelessness, or loneliness. Now, of course, emotions are natural, and we can't always control them. But what we can do is recognize them, reframe our thoughts, and then choose different behaviors, which in turn can reduce how often we feel stuck in these negative emotions. Over time, I noticed that clients who developed more positive coping behaviors, positive thoughts, and positive emotions were the ones who did better in their rehabilitation. So I began to actively work on this with my clients, helping them to reflect on how they were coping and build better strategies. And together, we saw some incredible transformations. As I spoke to more clinicians, I realized I wasn't alone. Many of us wanted to provide this kind of holistic care, but a lot of us just didn't have the tools or training to do it consistently. It was also clear that our clients wanted this care, and there was a real gap in training and resources that allowed us to help them in this way. And this is what urged us to develop the AIMER program. The AIMER program was developed by a multidisciplinary research team, including audiology, psychology, gerontology, and behaviour change research experts. The aim of this overall project was to develop an intervention to support hearing care professionals in addressing social and emotional wellbeing. And we couldn't have done this without the generous funding of the Rain Medical Research Foundation. Let's walk through the 4 main phases of the AIMER development process. Phase 1 really focused on understanding the need for holistic care. We conducted a series of focus groups and explored the lived experience of hearing loss from the perspective of adults with hearing difficulties and their significant others. And we also ran a series of focus groups with clinicians to deep dive some of the barriers and facilitators to providing holistic care. Phase 2 is where we then developed the intervention, which became the AIMER framework. Phase 3 is where we created an implementation program to ensure that AIMER could be embedded sustainably into clinics. And phase 4 was when we then piloted the intervention. We partnered with a major hearing clinic network in Western Australia to see how it worked in practice. Now let's dig deeper into that phase 1, where we sought to really understand the need for holistic care. To truly design a meaningful intervention, we first needed to understand the depth and nature of the problem. So we conducted 4 qualitative studies to explore the need for holistic care in audiology through the lens of both clients and clinicians. In the first study, we explored the lived experiences of adults with hearing loss and their significant others. We explored the emotional, social, and mental health impacts of hearing loss, how these experiences affected their daily life, their relationships, their self-identity. And we also explored the helpful and unhelpful coping strategies used by both the person with hearing loss and their significant other to try and manage these challenges. This gave us rich, real-world insights into how hearing loss affects people beyond the audiogram and the critical role of supportive relationships in coping. In the second study, we focused on clinicians and front-of-house audiology staff to explore the barriers to providing psychosocial support. So we held focus groups where we explored what kinds of psychosocial support they currently offer, if any. We also explored what they want to do but feel unable to do with regards to providing psychosocial support. And then we systematically explored the practical, emotional, and systemic barriers that stand in their way, identifying things like time constraints, training gaps, and role uncertainty. This helped us identify key areas where support systems and training could make a real difference in clinical practice. The third qualitative study we conducted looked at using mental health screeners in audiology settings. We invited the same groups, so clinicians, clinic managers, and administration staff, to evaluate a set of evidence-based mental health screening tools already used in other allied health professions. Through focus groups, we explored how comfortable they were in using these tools in audiology, whether they thought their clients would accept or benefit from adopting these mental health screeners in audiology practice, and also what they saw as the barriers and enablers to integrating these tools into routine care. This helped us clarify where screening may be feasible and where it might require adaptation or more support. The fourth qualitative study we conducted explored barriers and enablers to mental health referral. So this was looking at when and how audiology professionals refer clients for mental health support. Our focus groups uncovered who in the clinic is more or less comfortable referring. We also explored what knowledge, skills, and resources staff felt they needed to do this well, and how existing referral processes either help or hinder timely support. This allowed us to map out where breakdowns occur and where targeted interventions could build confidence. Moving into the second phase of work, this is where we started to develop the AIMER intervention. We used a structured framework called the Behaviour Change Wheel, created by Susan Mickey and colleagues in the UK. This is an internationally recognised method for designing behaviour change interventions in healthcare. The first 3 steps of this process involve defining the target behaviours, understanding what influences those behaviours, and selecting which behaviours to focus on. To achieve this, we ran stakeholder workshops with adults with hearing difficulties, their significant others, hearing care professionals, clinic managers, and front of house administration staff. We asked them to think about what happens when a person with hearing difficulties is experiencing emotional or social challenges. Who do they interact with? What kind of support they might need, and what could each professional or family member do to help? From those conversations, the participants identified 37 different behaviours that hearing care professionals could potentially use to better support their clients' social and emotional well-being. But we couldn't tackle all 37, so we asked participants to vote on the ones they thought would have the biggest impact. The top 3 behaviours that participants voted for were asking clients about how they're coping with the mental and emotional impacts of hearing loss, providing information about the common social, emotional, and mental well-being impacts of hearing loss, and offering personalised information and strategies to help the client manage those challenges. These became the foundation of the AIMER framework, the 3 behaviours that the AIMER framework targets to help improve clinicians' abilities to provide that psychosocial support to clients. So next, we needed to understand why these behaviours weren't already happening in clinical practice. We used a framework called the COM-B model, which stands for capability, do clinicians have the knowledge and skills? Opportunity, are the systems or resources in place to make this possible? And motivation, do clinicians feel confident to see value in doing it? We interviewed 15 hearing care professionals to explore these factors in depth. Here's what we found. Common capability barriers included things like clinicians feeling like they lacked knowledge, skills, and language to have conversations with clients about emotional well-being. Hearing care professionals also described that they weren't sure what sort of information to provide their clients. They had an understanding themselves of the social, emotional, and well-being impacts of hearing loss, but they weren't sure how much to tell or share or what sort of information to give their clients. And they also lacked clarity on referral pathways. Opportunity barriers included a lack of time and resources, feeling like they didn't have clinical tools to help them have these sorts of conversations and provide this sort of information and support. And some clinicians said that they felt unsupported by their managers or peers in their workplace systems when it came to addressing psychosocial well-being. Now, motivational barriers included the perception that talking about mental well-being may not be within the audiology scope of practice. Some clinicians were also worried that clients may not want to talk about social, emotional, and mental well-being issues, and that perhaps it's a taboo topic, something they shouldn't be talking about in clinic. And then there were a few clinicians who were concerned that nothing could be done to help clients, that depression is a common consequence of aging, and that there was no point in referring people or trying to help individuals because there was nothing that could be done to improve their situation. In total, we identified 110 unique barriers across the 3 behaviours. Now, of course, we couldn't address all 110 barriers because that would make for a very unwieldy intervention. So working closely with our clinical partners, our research team, we prioritised 16 key barriers that were commonly reported, most modifiable, and most likely to shift behaviour if addressed. These became the focus of the AIMER intervention program, and this is what we're going to explore in this next section. To build the AIMER program, we moved to steps 5 to 7 of the behaviour change wheel, identifying intervention functions and behaviour change techniques. Here, we reviewed the literature to see how other research programs had tackled similar behavioural challenges, such as helping clinicians ask sensitive questions or deliver complex information. And then we mapped those behaviour change techniques to the 16 priority barriers that we had identified earlier. For example, one common barrier was that clinicians didn't feel confident about the language to use when discussing mental well-being. So we built behaviour change techniques like knowledge transfer through example scripts, flashcards that show how one might respond with empathy to common client concerns, and video demonstrations of real clinical examples, as well as skill building through role-play exercises. Now, this process was methodical. Every barrier had one or more behaviour change techniques specifically designed to address it. This resulted in the AIMER framework. Now, AIMER stands for ask, asking about well-being and coping; inform, so informing clients about the common mental well-being impacts of hearing loss; manage, so to help clients collaboratively develop strategies to better manage the well-being impacts of hearing loss that they're experiencing; encourage, to validate and reinforce positive steps; and refer, so referring clients for further support when additional support is needed. Each step plays a unique and essential role. For example, ask builds trust and gives permission to talk about challenges. Inform helps clients make sense of their experiences, validates what they're going through, and helps them realize they're not alone. Manage brings shared problem solving into focus. Encourage helps maintain motivation and gives clients permission to put their needs first. And refer ensures clients get comprehensive care when needed. We didn't just stop at a framework though. We developed a full intervention program to support clinicians in how to use the AIMER framework. This three-pronged program included education, training and enablement, environmental restructuring, which is building tools directly into their clinical workflow, and then modelling and mentorship, so using real clinician role models to show AIMER in action. Here's a sneak peek of a few of the AIMER intervention components that we'll dive into in more detail in a few of the future videos. One major concern from clinicians was the belief that clients didn't want to talk about well-being, that it might be too personal or taboo. To address this, we did two things. First, we interviewed adults with hearing difficulties and asked if they experienced social or emotional impacts and whether they would have liked their clinician to ask or offer support. If you watch video 1, you'll remember people like Jan, Jennifer, and Doug. Their responses were overwhelmingly clear. Yes, I wish my hearing care professional had asked me about this, created a safe space for me to talk about the social and emotional impacts of my hearing loss. I needed that space. I needed that opportunity to discuss. I needed that support. Second, we developed a client-facing priming video, an animation about the well-being impacts of hearing loss. This was sent as part of a client's appointment confirmation, prompting them to think about how hearing loss was affecting them emotionally. It served two purposes. One is that it primed clients for the conversation, but second, it also reassured clinicians that their clients would be expecting the topic to come up during the audiology appointment. Now, another barrier was not knowing how to start the conversation. So we co-designed a visual discussion tool with adults with hearing difficulties. This printable page of feelings commonly associated with hearing loss. Clinicians can use this by placing the page on the desk and inviting clients to point out emotions that resonate with them. It's a gentle but powerful way to open the door to meaningful conversations, but we'll talk more about that tool in the next video. We also heard from clinicians that they sometimes forgot to ask about well-being. Not surprising, given how much is packed into a single appointment. So we embedded prompts into the case note forms that clients complete in the waiting room. This ensures that wellbeing topics are raised early and presented back to the clinician. We also added case note prompts to help clinicians document these conversations. The exact wording varied by clinic depending on their workflow, but the goal was the same: make it easy to remember and easy to act. Now, another barrier was knowing what to say and having the right resources. So we developed training modules to help clinicians share information in a helpful way. We also created 3 client information sheets, one on the social impacts of hearing loss, the emotional impacts of hearing loss, and a third on how hearing loss can affect relationships. Each included examples, case studies, and practical tips, not to replace the conversation, but to support it. Altogether, there were dozens of intervention components, each one linked directly to a specific barrier and designed to support one of the 3 target behaviours. We wanted to show that this isn't just a collection of good ideas. AIMER is a systematically developed, evidence-based and rigorously tested program. You can find all of the AIMER materials and research papers on this website. They're open access and ready to use. Now, step 8 of the behaviour change wheel was to define the implementation strategy. To clarify, the intervention is what we're doing, and the implementation strategy is how we make it happen in the real world. For AIMER, our implementation strategy included a half-day in-person workshop, self-directed learning videos, a mentoring program, and a train-the-trainer model to embed AIMER across the clinical organisation. In the final phase, we partnered with the Hearing Services Organisation on the west coast of Australia and implemented the AIMER program in partnership with them across their organisation. This included training staff and embedding tools into their system. We evaluated the program using 5 key outcomes: staff survey, weekly clinical diaries, case note audits, GP reports, and staff interviews. First, let's look at the staff survey results. We sent all of the staff a survey before and after the AIMER rollout. While we asked a wide range of questions about their knowledge, their skills, and their behaviours, I'm just going to show you a snapshot here. If you look at the results, we found that the vast majority of clinicians indicated that they had experienced an increase in knowledge after being involved in the AIMER program. So undertaking the training and practicing putting in place the resources helped them increase their knowledge in how to support the wellbeing needs of their clients. And over 50% reported this to be a large increase in knowledge. Over 96% reported improved skills, and 82% noted increased confidence, with half describing this as large or very large improvement in their confidence. Next, let's look at the weekly clinical diaries. So we gave clinicians a piece of paper to stick on the back of their clinic doors, and every Friday we asked them to fill in this form. They were to make a note as to what proportion of their clients they had asked about wellbeing, provided general information, or provided management support and referral. They completed these diaries for 6 months before and then 6 months after AIMER rollout. Before I show you what we found, let's take a moment to reflect. I'd like you to think about your own clinical practice. On average, how often do you ask your clients about how they're coping? How often do you provide general information on the social, emotional, and mental wellbeing impacts of hearing loss? And how often do you offer targeted support or referrals to help your clients specifically manage the issues they've discussed with you? If your answer is few or none, you're not alone. Before the intervention, most clinicians reported that they asked only a few clients about wellbeing. They gave information to only a few, and they offered targeted support or referrals to virtually none. But after the AIMER program was implemented, asking about well-being increased significantly, from few to most. Providing general information remained stable, but offering management or referral support increased from none to few. The third outcome we looked at was case notes, and this one was a surprise to clinicians. They didn't know we were going to be auditing their case notes as part of this study. We audited their case notes for a 3-month period before and after the AIMER intervention, looking for well-being related terms such as lonely, anxious, sad, left out, and so on. The reason we did this is because we wanted to explore whether it was not just their behaviours in the appointments that were changing, but also how they were thinking about the psychosocial impacts of hearing loss on their clients, and whether they were then documenting these psychosocial impacts in their clinical case notes. Now, before AIMER, only 29% of case notes had psychosocial content. So only 29% of case notes used at least one psychosocial term. But after AIMER, that number jumped to 55%, a statistically significant improvement. Interestingly, we also saw an increase in the number and variety of terms used per entry, showing that clinicians were not only having conversations with more clients more often, but they were also more attuned to documenting the depth and breadth of the social and emotional well-being discussions they were having with clients. We ran the same audit on GP reports. Before AIMER, 3.6% of GP reports included well-being terms, and after AIMER, that increased to 6.4%, another statistically significant shift. Finally, we interviewed participating staff to learn more about what worked and what didn't, and how we could further improve the program. Their insights have been invaluable and continue to shape the future of AIMER. As one clinician said, "This program has really helped us to ask the right questions, talk less and listen more. This then helps the clients to tell us what they really need from us, and helps us to address their hearing needs, as well as help them to overcome all the ways that the hearing loss might be affecting them." Another clinician said, "Different resources work for different clients, and it's about deciding which ones are suited for their particular personality or need, or how open they are to discussing mental well-being." So this brings us to the end of video number 3. But before we sign out, let's just take a moment. I'd like you to think about what stood out to you in this video. Did watching this video help you notice anything about your current approach or mindset in your clinical practice? Flip to your workbook and jot down one small change that you feel ready to make and 3 actions that you could take to move towards that change. Remember, progress, not perfection. Even one small shift can unlock deeper connection and more compassionate care. You've already taken the first step just by watching this video. So now, what's your next step? Thanks for joining me today, watching AIMER video number 3, Why AIMER Works, the Science Behind the Framework. In our next session, video 4, we'll explore what it really means to open the conversation about well-being with your clients. We're going to look at why asking matters, common clinician concerns, how to prime your client, tools and templates to start the conversation, when and how to use screening tools, and how to respond with empathy without needing to solve everything. Remember, you're not alone on this journey. Together, we're building a future where connection isn't a bonus, it's the foundation. I'll see you in the next video. Ciao.